Good morning, everyone. Karina Hill with the Florida Alcohol and Drug Abuse Association. We expect to get started on time, so in about 5 minutes, we'll meet you back here. This is a good time to go and grab a cup of coffee. See you in 5 minutes. Good morning, everyone. Karina Hill with Florida Alcohol and Drug Abuse Association. And on behalf of the Florida Alcohol and Drug Abuse Association, we welcome you to today's webinar entitled Natural Supports for Family Crisis Management. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode, and you will only be able to view your name. If you have questions, please send them to the presenter and me by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. The archived video displays what looks like to be an error message, but it's only a delay buffer. Ignore it, hit play, and enjoy. To access the recording and PowerPoint, go to www.fada.org, Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Friday, February 21st. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage, Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for recording to CE Broker when you register with our site for the first time. If you were certified with the Florida Certification Board or licensed outside of the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. Now I will introduce you to Trish Caldwell, our presenter today. She is with Family Services Director for Recovery Centers of America, an adjunct professor at Jefferson University, and a trauma trainer for Lakeside Global Institute. Trish is a licensed clinician, marriage and family therapist, and is certified in both co-occurring disorders and substance use. Trish has been a therapist for over 25 years and has worked extensively with families, young adults, and adolescents with co-occurring behavioral health and substance use disorders in various settings, including outpatient, residential, schools, and community agencies. She is trained in DBT and is certified trauma professional. Additionally, Trish created the first young offenders treatment program in Delaware County, serving first-time offenders with drug charges. Trish specializes in ADHD, opioid use in young adults, trauma-informed care, developmental trauma, trauma and substance use disorders, trauma in the family system, family engagement, and substance use for today's teens. Trish holds her MST from Drexel University and is licensed and certified in the state of Pennsylvania. During her career, Trish has held a variety of clinical and leadership roles. She is currently the Corporate Director of Family Services of Recovery Centers of America, which has sites in New Jersey, Pennsylvania, Maryland, and Massachusetts, and provides services to adults seeking treatment for substance use disorders. Additionally, she is a member of the NOPE Task Force Partners for Success Coalition, and she holds a private practice specializing in adolescents and young adults who have been diagnosed with ADHD or trauma. And now I would like to welcome our presenter, Trish Caldwell. We'll turn the presentation over to you.
Thank you. Good morning, everyone. I appreciate you turning in. I'm thrilled to be here to be able to talk about one of the passions of my career for the last 25 years, and that's ways to engage the families throughout treatment for the people that we're serving. So today we will be discussing various ways that we can engage the families, understanding some of the barriers that have presented for the families in the past, and the importance of what we want to do in regards to how to get them involved. So as you heard, if you have any questions, please feel free to post them on the Q&A. I will attempt to try and integrate them into the training so that I can answer them as they come up. Otherwise, I can get to them towards the end. All right, so today's objectives are to define the term natural support as it pertains to crisis planning and management. So what exactly are we looking at when we say that we want families to be involved? What is a natural support in regards to how to help somebody through the recovery process, whether the crisis is mental health related or whether the crisis is substance use related? To differentiate between the various natural supports and ways to engage them into the treatment process. So that is what the overwhelming majority of my career has been, is attempting to find ways to engage the natural supports that would allow for systemic changes to occur for that individual. And so we'll talk a little bit about what the research says in regards to that, but that's a huge part of what we'll be discussing today. Listing 4 of the critical clinical reasons natural supports need to be included. So we'll discuss why is it that we need them to be involved in the treatment process, and what do they have that they benefit from being a part of the treatment process, as well as the individual that we're working with. Understand how family-based approaches and family-centered recovery supports help foster resilience and boost our protective factors. So again, another huge part is how do we empower these families to understand that they are the key to the success that they want to see within the changes for their families. So identifying the protective factors and also building their own internal resilience, which every family, and I'm going to argue that as we continue through this, every family has its own internal resilience. So how do we identify that for the families? How do we help them see it so that they can utilize this as a part of their recovery process? And then list a couple of treatment outcomes that are increased by enhanced family involvement. So I always like to start these trainings when I'm talking about families because I think there's so many different understandings of the word. So when we think of the word family, what does that conjure up for you? What do we think of in regards to, so who are we supposed to involve? So again, I work in a substance use treatment facility where part of what we have required is the involvement of families. So that's an interesting thing within the field of substance use, that historically what you notice is that families are not involved. And so being a part of facilitating, we know that recovery happens and is strengthened. Again, whether the recovery is from substance use or some mental health struggles, but we know that recovery increases and is sustained better when people are surrounded by support. So looking at that meaning of what do you think of in regards to who makes up somebody's family? And I'm not going to go over some of the definitions of kind of what family is, but I think that what we've become what we become really focused in on is family as this natural support. So family is the households to which we live. And so that can vary, again, depending on where you are working with an individual or what you're working with them. Because for us, for treatment facilities, sometimes the families are the ones that they're living in is a recovery home. And so involving their sponsors, involving the team leaders of the recovery home become an important piece to maintaining and sustaining long-term recovery. When we look at kind of the family as that natural support, it is a primary way that we pass on our own cultural traditions. Family is kind of where we start to learn the rules of what we expect. When we're providers, we see the importance of that because we're seeing the rules within the system by the patient's behaviors. So how do they interact with them? What does communication look like? I use this example all the time in talking with some younger interns. They were working with a family that they had just begun working with. And again, this becomes really important as a part of that natural support, is helping families to identify their own strengths is not about us identifying what we think a family's strength is and then trying to get that family to then replicate it. And so here was a young intern that was doing a wonderful job working with families, but what she was very clearly used to was a very interactive family, eye contact, and tell each other how you feel and tell each other how much you love each other. And what it was doing for that family, and that's that primary pass that we pass on these cultural traditions on how we interact with others, is it was increasing the anxiety experienced by these families because the patient was being asked to do something that was culturally not in alignment with what they had learned. And so here we are working through substance use, and now the family is being asked to do something by giving direct eye contact, by sharing these emotions that they are not comfortable sharing. So paying attention to the family's needs and paying attention to how they interact with others. What are the establishments of the rules that they have set? So when you're looking at how child rearing has occurred, when you're looking at what those roles look like and what the rules are in regards to how families decide that they're going to communicate, what the hierarchies look like within the system. Because again, we're not trying to get families to become the families we wish them to be. We're trying to get families to identify their own resilience so that they can be the families they choose to be. That's kind of the difference in the role of us as supporting their natural support systems. And then looking again at that complex in the definitions, the responsibilities, the interactions, because some of the families might engage in, and we'll talk about that as we get a little bit further down, but in the recovery process, I say this a lot, when a patient is being offered a choice between recovery or their family, most patients end up choosing their family because the complexity of the relationships, because people choose loyalty over almost anything else, that it becomes really important to involve those family members, because sometimes the behaviors that they end up learning as a result of the experiences of the crisis, and again, I'm going to keep saying that I'm saying recovery, but recovery can be from mental health, recovery can be from substance use, recovery can be from the crisis. So it's not always a recovery as in substance use. But when we're looking at the intertwined nature of this, that families start to surrender and circulate around the recovery process based on their history, and sometimes those behaviors can either support the recovery or without being appropriately involved in the treatment process. Sometimes families just perpetuate what they've already done, and they end up behaving more chaotically or surrounding more of the chaotic behaviors. And so getting them in becomes that much more crucial, because I've seen a husband or a wife that have inadvertently undermined what recovery should look like because they didn't understand what the process was, because nobody had provided them education and support into how to become a part of the recovery, as opposed to, in this circumstance, as opposed to the addiction. So that becomes an incredibly important piece. I like to say this all the time. When we're doing treatment, family is whoever has your back when you're leaving our property. So the families are going to make up of, it can be a pastor, it can be a sponsor for a lot of us in our field. We might have to find sponsors for some of our patients that maybe are not speaking directly to their primary families at this point. So looking at opportunities to identify who's going to have your back when you leave this treatment process, who's going to be able to support you as you continue on this journey towards long-term recovery. So then who can be that natural support, as we just kind of mentioned? Spouses, parents, relatives, aunts, uncles, nieces, nephews. I've seen that. I've seen nephews coming into treatment facilities to be a support to their uncle. Community connections. So when you have a patient that is involved in the community or has involvement in the community, the stronger you can unite them within the confounds of what a family is, and that extends to whoever has your back, the bigger the resilience you're going to build. Sometimes they can be the peers that they meet in treatment or support, again, through fellowship, through people that have had shared experiences. There's a lot of mentorship programs today that offer that as a natural support, where they're able to engage in having conversations because somebody has walked a similar path. So then family involvement. What we know for certain, based on the research that continues to be presented, is that those who have family involvement more often seek and remain in treatment. And in a little bit, I will refer to a study that was done by Voice and Vision, where it actually highlighted, who are we going to when we go into crisis? Who is the one that we end up going to if we need to seek out additional treatment? And so that importance, so again, as providers, not only is this clinically the most relevant piece of information, because we know that those that are going to get them to our door are predominantly at the hands of a family member. And again, keep in mind the definition we just extended to family. So for family is whoever has your back. Family is whoever is going to be the support for them on the outside. And so when we're looking at this in regards to the treatment model for substance use, this is an interesting field. And again, I've said this, and I've spent 25 years plus throughout various fields, so substance use, mental health, adolescent treatment for long-term residential treatment facilities or short-term inpatient. And what I've noticed is within the field of substance use, there is a significant disconnect between the appreciation of knowing that this is a family disease, and we hear that often, right? Addiction is a family disease. But yet there's a lack of appreciation in recognizing the importance of getting the families involved. And so a lot of times what we come into contact with, and again, where I'm currently working, that's a big piece for our programming, is families need to be involved. We know that this lends to better outcomes. We know that this strengthens recovery. We know that this changes people's lives, and people want to stay connected. People are scared. People love their loved one that are struggling with this disease, but their anger and their fear can consume them. And so when we're looking at this, you look at the idea that addiction is a disease of isolation. And so what happens is that the patient ends up isolating in regards to the disease. So as the disease gets bigger, the isolation becomes more and more prominent. And so that wedge of disconnection gets larger and larger and larger. And with the families, what we have found is very similar. Because of the shame and the stigma associated most often with this disease, families will also start to engage in isolative behaviors. And so they no longer are getting the support from families and friends that they've had, people that don't understand the disease, people that might be offering them unsolicited advice about what you need to do or how you need to do it or what tough love is. And so as a result, what we're finding is that the families also isolate, and then they only know the behaviors associated with the disease. And so part of when we start talking about how do we engage these families is going to be in the way that we respond to the families from the onset, where we're not only involving those families during the crisis. That when we start to look at how does healing start to occur in the disease of addiction, or if somebody's struggling with mental health crises, that what we know, and more science is starting to demonstrate that, is that our ability to connect with others increases not only the resilience of the individual and the family system at large, but it also increases the opportunities to have hope, which can generate some of the most profound motivation for change. That when people believe that there's people that believe in them, they are incited to have motivation because they start to believe in hope. And so that becomes another really critical piece to helping to support long-term recovery, is how do you have families who have historically stood by somebody that they've loved, struggled with watching them involved in various crises, still want what's in the best interest, but their anger and their emotions have gotten so overwhelmed by them that they start to disconnect. How do you get a family to then reconnect to this person while starting to separate from the chaos? I apologize. I am slightly under the weather, so if you hear a pause, it might be so I'm going to have a cough drop or a glass of water. So when we start to look at this idea of crisis impacts everyone, again, I can't emphasize enough, we know that this is a family disease. We know that families are inherently impacted. If you care for somebody that has been impacted by any crisis, there's no way a family can't have also been a part of that impact. And so, again, when I talk about like the treatment world, and you can look at that in any treatment, is if we think about what we are offering to the patients, somebody comes in for a crisis, or if somebody comes in for substance use, that they are offered 24-hour care, that they have groups, that they have individual sessions, that they have access to psychiatry, they have access to interventions, support, peers, all in the interest of helping them to learn new skills to build a life of recovery. When we think about what is offered to the families, oftentimes the families are left in the same place that they were the day they brought their loved one to treatment. And so families haven't learned 24 hours worth of skills. They haven't learned 30 days worth of treatment. They haven't learned this new language of what recovery is supposed to look like. They've been living in the existence of what life looked like the day that they brought their loved one to treatment. And so if we think about an inpatient treatment for substance use or for mental health, that those are oftentimes plagued with some of the most horrifying experiences that somebody might have had. To have to make a decision to say, I think you need to seek continued care, suggests that a family felt out of control, and certainly the patient felt out of control. And so when we get that understanding of how did somebody, how is the family still behaving in some of these, these old ways? And I hear that sometimes within clinicians, and you hear that within the field of, people saying, oh my gosh, these families are still doing the same stuff over and over again. It's getting frustrating. They keep reminding the patient of everything that they've done in the past. And my question is always, have they been a part of the changes the patient has made? Because otherwise what you are asking them to do is to ignore their instincts. And when we start to talk about how trauma has impacted the families, we'll get into that a little bit more. But to just tell a family member they're fine today is not sufficient to a family who has experienced the trauma of having somebody go into crisis. And so families, if they are not involved in that process of how it looks and how it has changed, then they will oftentimes only be circling in on the day that they brought their person to treatment. And so that is where they start perpetuating. So when I have that for a system that's used to the crisis without getting treatment themselves, what we have found is families engage in old behaviors, perpetuating the crisis. So some will argue in the field, right? So they'll use words like enabling, they'll use words like codependency, which are oftentimes just leaving families feeling overwhelmed and shamed. The reality is that these families are doing what they thought was going to work. And again, when we talk about how trauma impacts the way that perception occurs, the reality is that if their loved one is still alive, then their brain has reinforced everything you've done up until this point has worked because they're still alive. Survival has still existed. And so whether it was yelling, whether it was checking cell phones, whether it was checking text messages, whether it was, kicking them out, not kicking them out, all of these confusing messages for families, they will continue to perpetuate the old behaviors until they have been given the support to learn the behaviors that would be more conducive of recovery for themselves as much as their patient. And so another important piece I think people don't take in consideration is when somebody is hospitalized for substance use or mental health, both the separation and the reunification can be stressful to the family. So the separation is oftentimes overwhelmingly stressful initially, but there's a sense of relief to it because the families finally know that they're going to be okay. And you might hear that if you've ever reached out to a family shortly thereafter and they say, I don't want to get involved. I don't want to do this anymore. I'm just happy to get a good night's sleep. And so that becomes another part of the conversation that we're having with these families. But the reunification, so when we talk about things like aftercare, which oftentimes families are not involved in, the anxiety associated to the families in preparation while they're super excited for their loved one to come home and while they're pleased that their loved one has done well in treatment, the anxiety associated with the reunification becomes incredibly stressful as well if they have not been involved in the treatment. Because again, keep in mind that family's last experience was what led them to coming into treatment. And so that's a huge part of making sure that as we're doing this, that we're including the families throughout treatment, including aftercare. So when we look at who are the supportive demographics, most family members today are being cared for that are under the age of 40. Almost half live in the same household or are very close to them. So sometimes you might hear somebody saying, I don't need to be involved with my family. I'm not living with them, but they live within 20 miles and are still probably their number one resource in regards to needing treatment. Excuse me, hold on one second. Sorry about that, I apologize. And over almost half are financially dependent on family. So when we continue to kind of look at that idea of the role of social support, the lack of social support and frequent feelings of loneliness increase all of those experiences that we've just discussed, the isolation, the death rate. And so when people feel connected, when people feel that they are not alone, when they have a will to survive, we see significant increases in resilience, in fighting through. And so what I want to make clear is a reoccurrence of a crisis or substance use does not mean that a person is not progressing. And so I don't want that to get confused, is that somebody that has a reoccurrence of their disease, somebody that has a reoccurrence of a mental health episode, does not mean that they weren't trying, does not mean that they are not still trying to actively seek recovery, that those are sometimes natural progressions of any chronic illness. That what we're saying is that with the role of social support, a person is more likely to continue to fight despite a reoccurrence. that if they have a reoccurrence of their substance use, if they have a reoccurrence of their mental health, that they'll continue to get the treatment that they need and continue to be motivated towards long-term recovery. And so that's a huge distinction, that when we isolate them, because I think, again, old school philosophy was cut them out of your life and they'll be more motivated, is what we're finding is that that wasn't effective. Is people want to see and make changes for themselves, but they also do that in the context of the people that they are surrounded by and the people that they love, who they don't want to hurt, who they want to have a relationship with. And so when we look at that, having people to not isolate increases resilience, increases their ability to fight and become motivated to sustain themselves within treatment. So when I had mentioned a little bit earlier, we might take a break in just a couple of minutes. I'm going to finish up this slide. I apologize. I'll get some additional cough medicine in my throat. When we had mentioned the Voice and Visions Family Involvement Project, what they had started to identify, and these were those family trends. So again, what are we missing when we're talking about mental health and drug and alcohol treatment? How do we evaluate and grow from these findings? These findings became incredibly telling. And so when we started to look at it, this was a research project that was done in order to assess how families felt in regards to the treatment process, as well as how the patients felt in regards to the treatment processes. And so there was 496 people interviewed over the past 5 years were asked, who do you turn to for support? So when we start thinking about, and again, if you work in the field, you hear the resistance and the hesitancy from the patients saying, I don't want my family involved, they've been through enough, or they're not going to want to do this, and hold on to various reasons. But when we're looking at, so then when we talk about that idea of how do we help families become a part of the recovery, not the crisis, this is a perfect example. Who do you turn to for support? 74% of those that were monitoring their own crises said they turned to family. And so what that starts to suggest is we know that the families are almost the first person for the majority of those that we are working with who are going to get involved if there is a crisis. And so what helps them to prevent the crisis or a relapse, 40% said family or friends. And then when they're saying what's helping them to prevent it, over 80% replied contact family or friends. So when I had mentioned earlier that families start to become oriented to the crisis of addiction rather than the language of recovery, this is perpetuating that. Patients are going to come to them when they're in a crisis or when they have had a crisis, reaching out for additional help. But then once they were getting into the treatment world, families were no longer involved. So they were not learning the language of recovery. They were learning just the language of how to support somebody in chronic crisis. So with that, I apologize. I'm going to just take a couple of minute break and get some additional tea and water and try and help offset some of this coughing. If you have any questions.
Okay, so we'll see everyone back in about 2 minutes, so 10:36. Thank you.
Okay. I apologize. Thank you for your patience with me. I apologize for that. All right, so as we were talking about some of the findings, so again, what we're noticing in regards to treatment, and so we're all working towards the same goal. We're looking towards maintaining and motivating long-term recovery. And so what the findings on that last slide showed was our patients. So even if the patient is saying, I don't want my family involved, I don't want to have my family there, that what we're identifying is that patients are reporting that when there is a crisis going on or when they need additional help, what they're doing is going to families. And so that becomes an important piece for us when we're having conversations with our patients on having them sign releases of information so that we can involve the families, which is a huge issue for a lot of providers because they will say the patients just simply won't sign a release of information. And so when we understand where the patient's concerns are, when we understand what's going on, we're able to have an honest conversation to say, I'm worried that if we don't get your family involved, that they're not going to know how to support you appropriately when you get out of here. And I'm worried that if you don't know how to have a conversation with your family when you are discharged or when you continue on in your transitioning, that might make it more difficult for you to also be able to maintain your recovery because of some of the emotions associated with those experiences. And so what they had on the findings, again, that the large percentage, so when we're looking at 69 to 88% of the patients are saying that they reach out to families. Here's where things have changed. At the same time, we're hearing from family members that they're only marginally involved, if at all, in their loved one's treatment. And so now we're looking at between 69 and 88% of families are the ones that our patients are going to in order to seek treatment if a crisis is occurring. And then the families are recognizing and stating, but then we're only marginally involved, if at all, when they're in the treatment process. So think about that. That a family can be surrounded by the chaos associated with the behaviors of any chronic crisis. But then as soon as the individual starts to get well, as soon as the individual starts to learn new behaviors, to identify ways to move through their recovery process, the family is not involved. And I'm going to give you an example of a family that I worked with that was in DBT, so the dialectical behavioral therapy. And this was a young adult and her parents. And in a prior place that she had been working with and also doing DBT, it did not facilitate like a multifamily DBT. So the DBT program that I was running was multifamily, so the families and the patients all came to the same groups to learn the same language. And what they had discussed was that this was a young woman who had a history of self-harm. And that history was obviously very traumatic to her family. They had found her where she had engaged in self-harm, that she had a history of suicidal attempts. And so what they ended up doing as a result, because she oftentimes did that in her own room, is they removed the door. And so she couldn't have any privacy because they were worried that she was going to hurt herself. When she started doing her own DBT and the family was not involved in treatment, what the girl was saying was part of her self-care and the way that she was trying to de-escalate when she would get agitated was she needed to isolate. And so she didn't have a door any longer. But every time that she was trying to engage in a skill to help her from engaging in self-harm, she would engage in a behavior that actively triggered her family. And when she would isolate, they would go in more. And so if she tried to go into a bathroom or another bedroom, they would become highly, highly triggered and would engage in like pounding on the doors. They would have called, they called the police because they weren't a part of knowing what the coping skill was. And so when we look at that, so here's an example of they only know the crisis, so they only know what they're trying to prevent. But once the behaviors start to be changed, or once somebody starts to learn new skills, because self-care is an important skill, and for a young woman, if she needed time to decompress, she needed to start separating the difference between avoidance and self-care. And so, but without the family being a part of it, they were continuing to engage in their old behaviors. So when she ended up meeting with me, which was later down the road, that was a conversation of that the family has to be involved. And that's a perfect example. The family was just saying, we're only marginally involved. We don't know what we're supposed to do differently. That when families reported in the same research that they wished it hadn't taken them so long to learn about available services and supports and how to best help their family members. This family was a perfect example of that. They were doing everything that they thought was going to save their daughter's life, and they were inadvertently engaging in behaviors that were increasing her anxiety and her likelihood of becoming more secretive to identify ways to kind of separate in her attempt to self-care. So family members will always say, I wish that I had done this before. I wish that somebody had told me this the last time. And so they're seeking it. And that research literature also confirmed that individuals experience more healing and greater success through the relationships in their community and their families. That one makes sense to me. And so when we're talking about it, that when people feel that there's people in their corner, they do feel more healing. This is not, and that's what I was making really clear before, doesn't mean that a reoccurrence can't occur. It just means that people feel that if I start to struggle, if I have a reoccurrence, I know I'm not alone. So this isn't to stop something, because sometimes that's what happens in regards to any chronic illness, but it's to that people don't feel alone, or so that people don't feel the need to create an increased amount of secrecy. Because in my world of substance use, secrecy is where this whole disease lives. And so we're trying to eliminate as much of the secrets as possible, flush out any secrecy. If you're starting to feel struggles, if you're starting to feel like you want to engage in substance use, if you're having these urges, that it's okay to share that. But you have to have a family that has been prepared for what that looks like and how to help them, or a conversation of this is why we encourage them to use sponsorship, AA, whatever that might look like. And that when we start to look at engaging in meaningful and sustainable treatment, what we're looking at is understanding the risks and vulnerabilities of how mental illness and trauma increase the likelihood of a substance use disorder. So these are all those things that start to interrelate, that families need to be, I say this all the time, families need to have as much knowledge as I do, because it's their loved one that they're going to be taking home with them. To understand, again, the key factors needed to engage them in treatment. So how do we want to look at that? That families are often not engaged in the treatment of their loved one. And as providers and families, we need to explore and better understand how we can engage those families to support recovery. So having conversations with them, making sure that we have initial contact with them, and identifying some of the potential barriers. So sometimes, again, because families are not always, sometimes it makes people uncomfortable to work with families. And so they'll start to assign a family's not attending a group or not attending meetings as they're not, they don't care, they don't want to do these things. And that is a judgment that isn't based on anything other than maybe some experiences or your own frustrations. But it is important to recognize that there's potential barriers for families. And we need to figure out what are those barriers. Is childcare an actual barrier? Because if it is, then we need to figure that out for a family. Is taking 3 buses to see you on a Tuesday afternoon a barrier for a family? Are tokens a barrier? Is work a barrier? All of these things are the barriers that if we're really trying to look at how do we create meaningful change, then we have to identify that these families are doing the best that they can and figure out what are the barriers that they're experiencing and how can we alleviate some of those barriers so that they can access the treatment that we think are in their best interest. Quite frankly, it's no different than what we do with the patients, and I say that all the time as well. If we treated the families the same way that we treat the people that we're serving, we would see similar outcomes. There's tremendous amount of change and hope because we'd be addressing it with them. So oftentimes I will say, so why are families not involved? Why do we sometimes leave the families in the dark? And what I will share with you is a lot of times what I say. So I do these conferences, you know, kind of nationally. And when I ask that question, so why are families not involved? Initially, they start to say, because they don't want to be, which I can almost rival any question in regards to that is, you know, the family says that they're done, they don't want to do this anymore. And I always say, so have you asked the family, is their loved one coming home? And they'll say, yeah, they're coming home. And I'll say, then they're not done. They're overwhelmed, that they're needing a moment of respite because they're feeling overwhelmed, that they're starting to lose hope, and that that's what treatment is all about. Treatment is about reinstating that hope for them, that while they can't control this, they can control part of their journey, and that they can stay connected to the person that they love and learn to separate themselves from the disease or the chronic illness. And so as we continue that, what ends up starting to come out is, I think, some honest self-reflection of people saying, I'm not that comfortable with families. It's overwhelming and it can feel scary, and there's a lot of anger and there's a lot of frustration associated with it. There's a lot of emotions and it feels chaotic because there's so many people. And so that becomes an important piece. And hopefully as we kind of do the second half of this webinar, that's what we'll kind of focus in on, is how do we get those families to be involved? And how do we contain a session that you're worried about because you're afraid that it's going to take over? How do you contain the session so that it becomes something that's productive, so that it's something that they can at least start this journey of learning this brand new language of recovery, because for however long the illness has been inside their lives, they've been speaking this different language. And so sometimes we project the notion that they don't want to participate because it's a little bit easier. When a patient says, I don't want my family involved, how easy are we to just say, okay, we asked? That's where we come in and say, that's like the person of the therapist. That's what we would call it in family therapy. You have to look at, so what about you is contributing to the families not being involved? Because we're all still motivated to the same thing, and that same thing is long-term recovery. And we know that it increases when there's family support. Oops, hold on 1 second. So what do we think are the barriers to engaging these natural supports? And these are, so when we're talking about how we want to understand what the families are worried about, why do they sometimes say, I don't want to come in, I don't want to be a part of this? That I always say these are important elements for us to keep in mind, because oftentimes families are riddled with a lot of shame and judgment and fear, and that there can be secrets in families, and all of that is okay, because again, what we're trying to do is build the resilience within a family. We're not trying to build a new family. And so when we're able to identify what are some of the barriers for them, it allows for us to validate their experiences. That if I'm thinking that this is a family that has shame, that I don't know how I could have let this get this bad, I don't know how we got here, or I wasn't the best mom, or I wasn't the best father, that when we can validate them to say, I can appreciate that you've done everything that you can, and that there's nobody that knows your child or your loved one better than you do. And so this isn't a forum where you need to worry that this is going to come at you. That what we're trying to do here is to identify the strengths that you already have, that the investment that you've already demonstrated in your loved one is clear, because here you still are fighting. So when you start to identify those barriers that they might have, we don't personalize it. And that's why I think sometimes can happen is that people will say the families don't care, they don't want to be involved. But I've worked with a lot of families that were scared about what was going to be different, or worried that somebody was going to judge them, or worried that somebody was going to say you weren't good enough when they were trying to do the best that they could. And so these become an incredibly important opportunity to just in carrying conversations with the families and having conversations with the patients of identifying what do you think are some of the things that we should be looking at. And then looking at other impacts or impacting the family. So again, financial barriers, we want to make sure that we're paying attention to work-related issues. So we're not just assuming a family's saying that they're calling out because they don't care, they don't want to be there. Are there financial barriers? Because it can be costly. The distance, transportation, if they've got childcare issues, these are legitimate factors that could impact the family's ability to be involved. And so that's that little piece of case management that if we're really trying to get these families to be involved, this is a great opportunity for us to do so and helping them problem solve. And so that's the other piece of getting the families involved, is building that resilience, is letting them know they have the ability to problem solve. But as we come back from the break, we're going to talk about trauma. And what trauma does is it stunts your ability to think that you can problem solve, because you're chronically in this fight or flight. You're chronically in the here and now thinking you need to do something immediate. And so when they're like, I don't have the money to get there. I've had family members say to me, I don't have the $3 of gas money to get to you. That's an appropriate boundary, but how much courage it took for somebody to say that for us to be able to look at ways that we could accommodate and look for ways that we might be either able to help, and if our agency is not able to be able to discuss other options for them. You know, if we were able to get them with other mentoring programming, do we set up phone conversations so that the families are still involved? But we're looking for opportunities for them to problem solve their own issues so that they are starting to utilize the cortex in trying to figure out how to be a part of recovery. And so when we talk about trauma, and I think this is where we will end up taking our break, how does trauma impact engagement? That we're going to do a little bit of a conversation of how that impacts the brain and how that impacts some of our decision making, and then kind of pursue how we want to get these families engaged. What are some of the best strategies? So again, if there's any questions, please feel free to put them in the Q&A, and I will attempt to look at that. But I guess this will be where we take that 5-minute break.
Okay, let's take a 5-minute break, and we'll see everybody back about 11 o'clock. Thank you.
Thank you.
Hello, everyone. Welcome back to today's webinar. Trish, if you're ready, I'll turn it back over to you.
Okay, thank you so much. All right. So I've been working in the field of trauma for a lot of years, many, many years. And that question came to me when I was facilitating an educational support group for families. And while I was, offering some education in regards to, various topics, there was a father there that said to me, "Can families have PTSD?" And I said, "Can you share with me what you're experiencing?" And what he discussed was the experience of what PTSD looks like, where I can't sleep anymore. I'm up all night worrying about whether they're going to come home or not safely. I am hypervigilant. If I hear a noise, I get startled easily. And he started to very clearly describe a life for a family member where they are living in chronic fear. And so today we are unfortunately in the midst of an epidemic where, whether it was primarily mental health in the beginning or whether it was primarily substance use, what has occurred is families are living in a chronic fear and sense of fear of death, that they're afraid. So if their loved one has a chronic illness, they're afraid their loved one is going to start to use substances. If their loved one has a substance use disorder, they're afraid that the substance use disorder is going to, ultimately end in their death. And so for a lot of families, we end up seeing the same behaviors that we might see in a patient. And so, when I have these conversations and I ask somebody to describe, if you're in an inpatient facility, if you're one of the acute facilities, whether it's, again, for mental health or whether it's for substance use, and you first meet these, the patients coming in, describe to me some of the behaviors that we might see. And what they start to describe is, irritability and agitation and, their difficulty with controlling their emotions, and transitions are oftentimes difficult, and they might be impulsive, and I'll say, so those are the signs, those are symptoms of PTSD. And then when I ask them to describe, and so wonderfully, so many clinicians do such a fantastic job in regards to patient care. And so when I say, so what do we do when we see a patient that seems agitated or angry or upset? We welcome them and we, encourage them to continue to fight for recovery, and we validate their experiences and we honor their stories. And then I say, so now describe to me what PTSD would look like in a family. And that changes their thought process, because what most people don't think about is, how would a family look if they had had PTSD? If you had a child, so for that young family that I was working with, a young adult, and they had witnessed their child trying to take her own life, that's traumatic. That when you've witnessed a Narcan or come home and found your loved one unconscious and had to perform Narcan, that's traumatic. And so once those symptoms start to set in, a symptom is a symptom, and the families will display it no differently than a patient. And so when I say, so how would we describe some of the families that you're struggling with engaging into treatment? They'll say angry and defensive and impulsive. And I'll say it seems like the same symptoms. And so that becomes a really critical piece to helping to find that kind of compassion in order to be able to motivate families. So if a family says, I'm not coming in here, I'm tired of all these things, that I can validate that for them. That I hear their story, I can hear their pain, and that I can say, I know how much you still love them. And I validate that you're still fighting. And so that is changes. And so when we start to look at, so how do we understand trauma? And again, this is not a trauma training, but in a very, very simplistic way to help understand, because I think that that's an important piece, is that all of our brains develop the same way from the bottom up. At the very bottom of our brain is the brainstem. Those are all of our instinctual behaviors that don't require conscious thought. So your heart rate, your respiratory, your eating, your sleeping, all of those things that are naturally designed for survival. When trauma occurs within our bodies and it's sustained, as it oftentimes is when we see these crises that occur within the families and the patients that we're dealing with, what happens is it changes the physiology of our brain all the way down to the brainstem. And we notice those changes very subtly when we can't sleep through the night, when we're up all night. We hear our patients saying, I can't sleep anymore, right? My diet's changed. I'm either eating too much or I'm not eating enough, right? So we start hearing those changes that occur at the bottom of the brain as a result of the increased stress hormones in our body, right? Increased adrenaline, increased cortisol. All these things are geared towards our survival. But when we are facing these things every day, and again, think about a family member who waits, and if you've ever worked with a family member of a substance user, then what you've heard is, I waited every day for that phone call. That I sat at home and I waited every day wondering if this was going to be the day that I got the phone call. And so when that occurs on a daily basis, what happens is that what is supposed to be adaptive in regards to brain development, in regards to that fight or flight, becomes maladaptive because it increases too much of the cortisol, increases too much of the adrenaline into your brainstem or your brain, and it organizes it differently. And so then you notice that I'm not sleeping as much and I can't eat as much, and all of these behaviors occur. As your brain continues to develop, the limbic system, which is the emotional part of the brain, becomes kind of the next in line. And so this is where the reward center is. This is where the hippocampus is, which is what retains memories. This is also where your fight or flight is. And so your brain is organized to help you to survive. And so when you're in your limbic system, it's alerting you. It has the amygdala, which is basically your smoke detector of your brain. And its job is to alert you to changes in your environment that you need to address to stay alive. Now, when substance use gets played into there, right, that's how those wires get crossed, because within the reward center is also in that limbic system, and then that hippocampus remembers, hey, that substance use helped you to feel better when you were having flashbacks. And so the limbic system in that emotion center, its job is to keep you alive. And all the way at the very top of our brain is the cortex. That's the part of our brain that allows us to think through the consequences. It's the humanity to who we are. It's our kindness. It's our generosity. It's our problem solver. But in regards to survival, if your brain is being triggered and you are dipped into that limbic system, the bigger the trigger, the less the cortex works. And so how that would be is if you were in the woods and you were about to get attacked by a bear, your limbic system, right, the pituitary gland sends a message to say release adrenaline, cortisol. And so it will shut down the information from the cortex because it doesn't want you to start problem solving. In that moment, it wants you to just to survive. And so it will shut down. And so we hear families saying that. We hear patients saying that. I don't know why I did that. I know better. I know I needed to do that, because what they were in when they ended up engaging in a crisis was in the limbic system. And the limbic system is reactive and it's impulsive. And it is associated with learning. So behaviors make sense, not always to the cortex. Because the cortex is only really being utilized when the brain feels safe enough to be able to utilize it. And so when we think about the families who engage in these, behaviors, when we look at multi-generational substance use or multi-generational chronic illnesses or mental health, then you're looking at a brain that has been offset where the limbic system was being more utilized than the cortex. And so you start to see an individual being more reactive, more impulsive, more living in that here and now moment because their brain has adapted to the traumatic experiences that they've been living. This becomes incredibly important when you start to look at how do we want to treat and get the families engaged? How do we recognize the signs of the trauma and still get them engaged? How do we provide them safety, which is huge and critical? How do we provide them safety? Because sometimes what people will do is say for family sessions in particular, the family will come in and unleash all of the pain and misery that they've experienced in regards to the substance use or the chronic illness or the behaviors associated with whatever the crises was, but that's not safe. And so part of that containment that I had mentioned earlier becomes that much more critical. Because if we're working with a family, let alone a patient that has experienced trauma, then what we need to make sure of is that while we're engaging these families, we're providing them safety. That we're containing sessions and helping them to understand why are we containing this so that they have a forum of understanding that they need to know how to get themselves regulated, that they need to know why they are experiencing these strong emotions, and to understand that that limbic system is taking over. And when they are rational, when they are calm, when they feel safety, they actually can activate their own problem-solving techniques. So when you've worked with families that have said, I don't know how to solve these things, it's because they are telling you, I'm in the limbic system too much. I can't see through things. I can't problem solve, but they can. They just aren't in their cortex enough. And so safety becomes an important, critically important element to the treatment process. And so when we're looking at the family events, these are all the events. These are things that happened on a day-to-day basis that start to alter that brain. Somebody coming into the home, police coming to the home, child welfare and protective services, that all of those things become triggering. And so for those of you that work in the child welfare system, you'll see that even before a parent is, the days leading up to a court date, you will start to notice that family member engage in the symptoms that I just discussed. The irritability, the agitation, they all of a sudden become more impulsive, and you're like, why would you do that? You've got court in 2 days. And they'll say, I don't know why. Because they're living in their limbic system, which is life and death, which is immediacy. They're not learning to get themselves calm, to utilize the cortex. And so, trauma sits inside of our body. So a parent that is anticipating going to court inherently is going to get triggered. And so those behaviors are appropriate. They just need to learn how to manage them. When we look at toxic stress and substance use, again, toxic stress is that's that daily, the most threatening, because it's prolonged activation of the body's stress management system. So when it is occurring every day, and again, sometimes people think of trauma as like a very specific event, but the way your nervous system works is that if you continue to be experiencing prolonged stress, it will alter your nervous system. And so that becomes in the absence of buffering that protective support. So that becomes a really incredibly important thing to notice for a family and to validate for them. The continued stress that this has been placed on them that you can recognize, because as a result of it, it's created a very strong limbic system dominant brain that is more reactive, more impulsive, more emotional, and engages in whatever they think has worked to survive. And so when we've looked at like the family traumatic responses, and I had alluded to this a little bit earlier, understanding what the behaviors are in regards to enabling and codependency is that they've actually done research with the family members who have had a loved one with a chronic illness. any chronic illness. And what they've identified is similar to the neural pathways that occur for a patient who gears towards certain behaviors. That when I've talked about families, kind of cycle around the addiction or the chaos or the crisis, that what they've learned in this research is that family members' neural pathways actually do focus around the disease. So that chronic illness, the brain starts to organize around it because we are organized to help our loved ones survive. And so when we're telling somebody that they're enabling, there's a neurological basis as to why they're engaging in these behaviors and why it's difficult for them to stop. So rather than just telling somebody, stop enabling somebody, that you can help them to see, your brain has learned that these behaviors have worked, but your brain is misleading you. And that what we want to teach you is some skills that will help you to support this world of recovery. But it's going to take time, and it's going to take patience. And I use the ski slope analogy all the time. If you're at the top of a ski slope, there's one pathway that's very fast, the one that you've gone down over and over and over again. And so trying to create a new neural pathway that supports recovery as opposed to the crisis is going to take time. And when you get to that top of the hill, every part of your brain is going to want you to go down that quick path that's fast and efficient. And what we're going to be asking you to do is to go down this other one that snow has not been impacted. And it's slow, and it's tedious, and it's going to be a lot harder. But the more you go down that one, the snow will start to get packed down. It will start to become faster and quicker and more efficient. And the one that you were doing will start to fill up with more and more snow. And so that changes the way that families feel, again, judged. So when we saw those reasons that families don't want to come in for treatment, the shame and the fear and the anger, that when you can help somebody to understand your behaviors make sense, and it's just time that we're going to try and figure out a new way to do it, then the families don't have the shame associated to it. I don't know why I keep doing this. I don't want to do this. I don't want to check their numbers. I don't want to live like this anymore. Then removing the stigma of saying, stop enabling somebody and saying, there's a neurological basis to this. This makes sense. We're just going to learn new behaviors. And so when we, again, how do those families organize around the disease rather than the recovery? That's what we've just discussed, right? The inconsistencies of parenting can impact attachment with their children. So when you have child and protective services, the children are going to display very almost predictable behaviors. And so developing a misplacement of an imbalance of duties within the system. And so this is how families start to organize around it. The neural circuitry starts to organize around those behaviors that are supportive of the disease. And not supportive in regards to, like, I hope that they continue to have this disease, but in supportive of, this is what I think is going to keep them alive. So me screaming, me making threats, me making, me disconnecting, all of these things, the inconsistency, that starts to create the organization around the chaos and the crisis. And so this is what we just talked a little bit about, so I probably won't go into this slide quite as much, but the codependency, again, when they're a loved one. And so I'm a big fan of knowledge. I do believe that the more that families understand, I also think that shared knowledge is the best knowledge. So when a family member knows these things just as well as I do, then family members get to decide how they want to make sense of it and how they want it to change their lives. But what I don't want is for them, because when I say somebody's being codependent, what will happen is that families will say, I don't know what else you want me to do. I don't know what else I'm supposed to do. And so the codependency, when you help them to understand this in regards to, it's just triggering, the codependency is the limbic system. You are engaging in behaviors that you think are going to lend them, your loved one's survival, but that's not how this works. And so it's not codependent. It's that you were doing everything that you thought you needed to do to help your loved one survive. And now it's time for you to learn something new. That's the difference. And that eliminates the shame. And so that's most of what I just discussed, so I'm not necessarily going to go into that because we just discussed that pretty much at length in regard to the family disease and the unhealthy neural networks. So that codependency is what impacts our relationships and our ability to have healthy relationships. If this isn't getting addressed, and that's where families can get involved and have healthy conversations, then the old behaviors are going to continue to persist because it's the only circuitry that they know. If you've only driven the same way to work every single day, it becomes automatic. And every time you get into a car, you drive the exact same way to work without even thinking about it. And so this is intentional changes. But if nobody told you that there was a shortcut and nobody helped you to understand how driving this other route was going to be more beneficial for them, then people will just do what they naturally always have done. And so that's not resistance, that's just natural human behavior. Families aren't resisting you by saying, I'm not doing that. If it doesn't make sense to them, then they're not going to follow through with it because they're going to do what their brain has already told them has worked. And again, when a brain has been impacted by trauma, those messages become incredibly important. And so families will oftentimes engage, and you hear this with families, particularly in substance use, but they'll pick up their loved one out of treatment early. Because when they get so triggered that something is going to happen to their loved one, they engage in old behaviors. They'll give them money to pay off, drug deals. They will, any of those behaviors that were once occurring will continue to occur. And then we talked a little bit about this as well, the professional, our own resistance to it, that sometimes we are not comfortable with families, and so we create a very comfortable barrier in regards to that. And so I'm appreciative that this is an opportunity for us to have this conversation. I'm always appreciative of being able to go somewhere to have a conversation about the importance of families, because what I find is that once we kind of get rid of the mystique of involving families, people are rejuvenated to say, wow, I really would want to involve the families. And I just felt overwhelmed, or I felt like it was supposed to be a screaming match. And just helping people to get the guidelines becomes incredibly effective so that people know how to bring the families in, to provide safety, to start to have a dialogue of what recovery looks like and how to have the language of recovery start to take over the cycle of addiction. So when we are talking about the family therapy point of view, and again, I'm going to go into this a little less, but people have said, so, if we're only working with the family 2 times, I don't understand how that can change anything. And so this becomes an important piece. The reality is that for a family therapy point of view, that any change within the system is a change in the system. If you put a nail in the spoke of a tire, it's going to change the tire. And so any change can create change and movement within the family. But an individual is oftentimes not strong enough, and I don't mean that as in like they're not, that they're weak, but it's not big enough to change a system. So if a patient is doing well, again, for this young girl, as I gave an example of, she wasn't strong enough. So she's working with her therapist at that time, who was saying, you need to tell your family that you need this time by yourself in order to take care of yourself, to reduce your likelihood of of attempting suicide. But that young adult was not strong enough. Again, not that she was weak, but in a systems perspective, she couldn't change a system. And so her family couldn't hear that, because they were in a part of understanding why is this being encouraged, because their history said that when she's alone, she dies. And so that becomes an incredibly important piece. And so even in 2 sessions, a family member starting to have a part of the conversation of where is safety, how do we put this door back on, because we're trying to get her to be involved in her own self-care and taking ownership, and also to free away the secrets, but that she needs to engage in self-regulation. the family needed to be a part of this conversation in order to support it. And so that's the family therapy point of view. So when we talked earlier in that objective, so why do families need to be involved? So that we can figure out their family roles, so that you can explore and develop their strengths. I don't need to work with a family to give them strengths. I need to work with a family to identify their strengths. They already have them. The fact is that they're sitting in front of you, so they've overcome tremendous adversity before coming to your door. They have strength to problem solve their own issues. But when we understand how trauma works, that in order for them to be able to problem solve, and I always validate that for them, I need you to calm that limbic system. So if you're triggered, you can't problem solve because your brain's not going to allow you to. It wouldn't make sense. So when you notice that you're triggered, calm your nervous system down, and that would allow you the problem solving skills. And so you see that when they're in their sessions with you, when you get them to calm down enough that they're able to have those conversations. And to address their own issues surrounding the addiction, that there might be things that they need to address, that there might be things, this might be multi-generational, that you can have a family member that's actively involved in their own crisis and still want the benefit of somebody else's recovery. And then these are reasons that we would want the families to be involved. So as treatment providers, we're going to understand behaviors. All behaviors make sense in the context of a system. You're going to get a whole lot of collateral information because historians, patients are not always the best historians in substance use as well as any other crisis-oriented behaviors. To gather the full assessment and to identify the resources in regards to if I know that mom is actively using substances and that son is going to be going home to her and he's an adult, she's not a sober resource, but she still can be a resource to him. And if he's aligned to her, if I don't allow her to be a part of his recovery in some capacity, this is that opportunity that I had said earlier. People will choose their families over recovery. And so I need to identify where is this family going to be the best resource for them. And then lastly, because when families are involved, we have higher rates of completion. So if you're looking within your own organization on how to get people to complete treatment and how to decrease somebody leaving treatment early, the more involved the family is from the beginning, the better your outcomes. That families can become a partner of the recovery process, that it's appropriate for a patient to say, I don't want to do treatment anymore. It's appropriate for a patient to say, I'm leaving against advice. Those are normal within the context of some of the issues that they might be battling. But when you partner with the family and they start learning the language of recovery, they've learned new ways to interact with their loved one, to support and motivate, as opposed to engage and go into their own crisis mode. When a family goes into their own crisis mode, that's the family that keeps calling and saying they need to be put on their meds, they need all these things. That's the family that comes and gets them because their own triggers have been occurring, and now they have dipped into that limbic system response, and they're engaging in behaviors that are not problem-solving oriented, but are more reactionary. And so when you can get them as part of the treatment process, you have better outcomes. So how do we begin to establish the relationship with the families? This is one of those things that I will say, oftentimes, when we are contacting families, and if we think about, again, our relationships within the work that we're doing, most of the time that we contact the families is when there is something wrong. So if a patient is about to leave the property, if the patient isn't paid their bills, if the patient is not showing up on time, and we continue to call the families, right? At the same time, we're telling families, stop enabling them, stop being so codependent. They're trying to learn recovery, but we are perpetuating this orientation towards the crisis. And so I say this, don't be the bill collector. When we think about a bill collector, if anybody's ever had the experience where they did not have their bills paid on time, if a bill collector called you, what normally happened is that somebody would decline it. You see a bill collector's number come through, you're like, decline, no thank you. And the reason being, not because you're being resistant or because you don't care, but because the phone call is coming and you don't have what they're asking for. So I'm not ignoring you. I don't have the money that you're asking me to give you. If I had it, I would take care of it. And for a lot of families, particularly when we think about with children, when I worked in the elementary and the middle schools, parents were only called, particularly for children with higher risks, during a crisis. And then they were surprised when the family stopped answering the phone. And they were like, now we can't even get a hold of them. We've got to send letters to them. And I would say, because you're their bill collector, it's a family that's trying to do the very best that they can at home, and you're calling them and letting them know you're not doing quite enough because now they're in trouble here, because now they're not doing well here. And so if we want to partner with a family, we need to not be the bill collectors. We need to be the people that are reaching out for both good and bad. And so we need to be calling the families with just no agenda other than to say, I just wanted to check in with you. I just wanted to see if you had any concerns that you wanted to address. Was there anything on your mind that you wanted me to be aware of? You know, I wanted to check in. Are there any needs that you have that I might be able to be a resource for? Because then you're building a partnership with a family rather than calling them and asking for something that they don't have. And you're calling the family to say, Johnny just got suspended again. They don't have what you're looking for. They don't know what else to do because they've tried and nothing that they've done has worked because they're also experiencing their own crises. And so that becomes a huge change in that game for them of just calling. And I will say, when I started at the company that I'm with today, that I started implementing that we were going to be calling families within the first 24 hours, and then we were going to call them again in the first 3 days by a primary therapist. And what most of the therapists were reporting is that initially, people are getting used to it now, especially if it's not their first time with us, when they would call the families would answer and say, what's wrong? And I said, correct, because they're used to the bill collectors. And right now, we're not calling the families because there's anything wrong. We're calling the families to partner with them. We're calling the families to say, I just wanted to reach out and let you know who I am. I wanted you to know what my name was, what my contact information is. If you have any questions or concerns, that you can call me. And so that was the changer. So we're going to take just another minute so I can get a little bit more water and calm down my throat, and then we'll come back and start highlighting some of these strategies for families to be engaged. Okay, thank you very much. I apologize again. So when we start talking about strategies for engaging families, And I think that this is the biggest piece, is that what I have found is on the patient side, probably the biggest obstacle that many have faced is that they can't get the patients to sign the releases of information. And while that's not on there, I'll probably touch on it just for a minute because it's such a crucial piece, because if the patient doesn't sign a release of information, there's nothing we can do. So it's a huge piece. But when we talk about the side of the families, and how do we get these families to invest, right? So again, we've understood that when trauma occurs inside of somebody's experiences, it changes the way that they perceive the world. And as a result, like that ski slope, the neural circuitry that perpetuates the behaviors that surround the chronic illness become the foremount, right? So those are the ones that the people are going to use most often. Those are oftentimes the ones we are also trying to change. So when somebody goes, if the patient goes into treatment, whether again for mental health or substance use, they're receiving a tremendous amount of treatment. They oftentimes do well in treatment, right, because it's structured, because it's organized, because some of the triggers are reduced for them. And so that can be replicated when we get the families to start to appreciate and invest in their own treatment process. What some people have said is, you know, I tell the families they need to find their own recovery, which families will find as defensive. And so that's not what we're asking people to do. What we're asking people to do is to invest in this process, because when they start to invest in the process, they'll feel differently and better equipped to be able to manage the crises for themselves and their loved ones. So I'm never telling a family, you need to find your own recovery, you need to work on yourself, because that feels like a judgment. And these are families that are saying, we've tried everything. And so I'm not invalidating the experiences that somebody's had by saying that. What I'm saying is, why don't you come in and why don't you be a part of this recovery process? Because what you might learn is some different skills that you might find helpful. And so in order to do that, and again, I've been doing this since I worked in that elementary school, which was probably one of my first jobs in a community-based program where I worked a lot with the Children and Youth Services, which was our New Jersey state programming, and worked with elementary and middle and high school. And so I've been doing this since then, 26 years ago at this point. And what I always felt was initial contact is so important that when I met, and so I'll use the examples of the children. So a lot of the children that I was working with were having issues with suspensions and getting kicked out, right? And so when you think about the bill collectors, what a family must have felt, right? That they were always hearing from the schools, always feeling that shame and fear of like just never being good enough. And quite honestly, when I met their children, I always found what I appreciated about that child. And so when I contact that family for the first time, it was only to tell that mom or dad or grandmom or whoever was raising that child what a wonderful job they were doing. And here was why. That initial contact, and so I never made up a story, right? Transparency is incredibly important when you're working with somebody that's been impacted by trauma. So I was never making something up, but I've never worked with somebody that I couldn't find this genuine hope and this kindness or this creativity or humor. And so I allowed for the family to realize, and so that they knew that that's what I was doing, that there is beauty inside of this child that you have been a part of. And we're going to get to some of those things, but nobody wants to partner with a bill collector. If the bill collector is calling you and saying, you know, hey, I'll partner with you and we'll pay off your debt. People are reluctant, but people will partner with somebody that says that they care. And so that became the primary reason for my initial contact. I'm going to call this family. I'm going to let them know. And if they didn't answer, it was okay. I left a voicemail. If they didn't have a voicemail, then I continued to call. And if I couldn't get a hold of them, I sent them a letter to just say, this is who I am. I've met with your child. and I adore your child, that this is what I really found that I enjoyed about meeting with them, and that their family had a lot to be proud of. Now, these are kids that might have gotten suspended for fist fights. They might have gotten suspended for all of these other behaviors, substance use, etc. But there was still the genuineness of who they were, and I wanted that family to know that. That was a game changer in trying to get families to be invested. And so that strong therapeutic alliance was that I was going to be the person that provided them with the positive information, and they were going to hear from me during the good times, and they could call me, and that when there was something that was going on, I was going to also be that person. So I wasn't saying you're only going to hear from me in the positive, but it was that you're not going to only hear from me in the negative. That was the big difference. That demonstrating respect and dignity, not to push the families when they're not ready, that if a family member was saying, I don't know if I'm going to do this, that I could validate their experiences. I could validate them attempting to do what was in the best interest of themselves. I could validate that they are feeling stressed or anxious about meeting with me, and that was okay. And was there anything I could do to help resolve that for them? Would it be helpful if we just continue to have these phone conversations? Would it be helpful if we did some of this over the phone? Would it be helpful if you just met with me? And so I can give respect and dignity to their experiences, because their experiences are what have led them to where they are today. Validating their fears and their frustrations, interpreting that reason, and so we talked a little bit about that, as are there barriers that I might be able to be a resource for you? You know, is this just that they're having a hard time getting in? And then when you're looking at helping, education is huge. And so, you know, I can't tell you how many times I would work with, you know, adolescents in particular and young adults, where the families literally had no idea what any of the diagnoses are that their kids were given. They have ODD, they have ADHD, they got bipolar, they got depression, and the families had no idea what any of these meant. And so I would always ask them, would it be helpful for you if you understood what these meant? Would it be helpful for you if I explained to you how somebody gets a diagnosis of oppositional defiant disorder versus ADHD? And families always said yes. And so that is showing them the dignity and care, right? So giving them education on addiction, if they have that, education on mental health and brain development and appropriateness of it. And if you aren't aware of how to do that, that you certainly can utilize resources of saying, hey, I've heard of this resource. This is a great place for you to go. This is a great website that might provide you additional information on bipolar or schizophrenia or addiction. That you're, again, that word partnering with a family, because what we're trying to do is get them to learn the language of recovery, whatever that recovery looks like for them. And in order for them to learn recovery, you need to believe that you have the ability to do this. And so you're utilizing this strength within the family in order to do that. And every family, and again, I've worked through a lot of different systems. I've worked with kids that have been in long-term residential, where they were removed from the home for 18 months. And those families also had resources and resilience and the ability to problem solve. It just took a little longer to get them to see it. And so finding out what the family's goals are, sharing what you think. So realistic goals are incredibly important. So when the family would say, I want him to, not get suspended anymore, that I was, again, because this is a partnership, I was saying, so that's a concern for me, because I'm not sure that that's a goal that we can have right now. So how can we negotiate how this might look so that it's more manageable for me, more manageable for you, and more manageable for your child? And so setting up appropriate, and then understanding that and respecting the resistance. So are they afraid? Because that's okay. Are they worried? Are they helpless? Helplessness is a learned behavior as a result of trying too many things that you felt never worked. That's what helplessness is. So when they say, I don't know what else to do, and they get caught in that you're looking at years of feeling a lack of support and understanding of how to change their own system. And so when you learn to understand that and you can respect the experience that they have, then you're not offended by it. I'm not offended if a family doesn't show up to a session that they were scheduled to do. because my goal isn't to make them do what I want. My goal is to do what's in their best interest. And so when I call and they're trying to make an excuse, I don't need them to give me one. It's okay that you weren't here. Can we set up another appointment? And then that becomes my direction. And then strategizing ways to keep their loved one into treatment. So what do you think that we need to do? And so again, that partnership becomes incredibly important. Recognizing the therapeutic reasons. So these are what we talked about before. It's just coming back in of like why we might see the families not do that. So that shame and the guilt. Secrets, if you work in the world of substance use, and when you're talking about child protective services, secrets are a huge piece because you might be looking at multi-generational behaviors. And so secrets can oftentimes be a barrier. And this is one of those, again, those opportunities. So certainly not when it comes at the hands of a reportable offense where we have to take action to make sure that we're ensuring the safety of a child. But there's ways that if we know that there could potentially be secrets, to create some space for that family to feel like this is a safe place for them to come where you're not going to judge them. Having very candid conversations about what you have to report, when a report would need to be implemented if you were concerned about safety. Here's why you would be concerned about safety. And then, again, partnering with them to say, outside of those scopes, this is an opportunity for us to say things might not have gone the way that you wanted them to, but that here you are still actively trying to change and implement the recovery process. And so that I can respect. And so when you look at those things, it allows for you to make those interventions. And so how to make those strong therapeutic alliance. Again, these are ways that at the moment that you first make contact with the families, to validate them and their struggles and their courage. I say this all the time, when you have a loved one that is inflicted with some chronic illness, it takes a tremendous amount of courage every day to keep fighting. And so I need to make sure that that family knows that, because what can happen is that they can feel overwhelmed and that they have nothing. But here they are through some of the most adverse conditions that they could have gone through, and here they are still standing, still trying to fight. And so they just don't have to do it alone anymore. That's really what the message is, that you're respecting that the family has their own unique story. And so asking them about their story becomes incredibly important. I said to one mom at one point, you are the expert of your own daughter. And she started to cry because her daughter had been in so much trouble for so long. She said, nobody has ever said that to me. And so this wasn't done to do anything to the mom. This was a genuine statement of, you are. There's nobody that knows your daughter better than you. I'm in your life for a short period of time, but you're in this for the long haul. And so you tell me what you need from me in order to be able to help you to move through this whole system. Honor their experiences and expertise, and listen. Listen to what the family's concerns are. Listen to what you think those barriers are. If this is fear, if this is anger, if this is helplessness, right, then you're looking at trauma. I can't trust anybody. Those words are inherently trauma aligned. And then looking at those family dynamics. When you start to change the family system, you're going to see the greatest outcomes. That's a fact. And that's been proven time and time again with research. Again, it doesn't necessarily prevent a reoccurrence, because that would not be respectful to a chronic illness. But what it does is it allows for people to continue to motivate themselves to the possibility of hope and change. That if you have a reoccurrence of, a manic symptom, if you have a reoccurrence of substance use, those are part of the recovery process, that sometimes reoccurrences occur, and the family being involved doesn't get rid of those. But what it does is it allows it to not be caught into the shadows, that families can continue to move forward and to recognize we fell off the bike and here we are still picking up this bike and moving forward. That's the difference. And so again, that goal of involving the natural supports is identifying the family's strengths so that they can begin to build their own life. And I can't emphasize that enough as well. The family's life should be in line with the life that they are choosing to live, not the life that we choose for them to live. So if you are a big communicator and you want this family to be a big communicator, then you've made that about you and not the family. If you are a big hugger, that was another one that had been done early on by an intern. She wanted the family to start hugging. They didn't do that. Generationally, that wasn't something that they were comfortable with. And so not to say that families can't change, but it has to be a desire that they want. It can't be something that we say is associated with what makes families strong. Hugging each other makes families strong. That's somebody's perception. It doesn't mean that it's another family's resilience. So you're looking at the actual family's strength to be able to utilize. And then the goals to explore the impact the crisis has had on both and help that family create a language of recovery. Help identify the triggers for both so that they can manage it, and that's where that becomes incredibly important. So, and I'll refer back to that young adult. The trigger for the young girl for her to use was when her family invaded her privacy, but the trigger for the family was when the girl isolated. If I did not pull those two together, that would have been a constant battle because she would have continued to try to isolate to engage in self-care, and they would have continued to be triggered by it and ripped off every door inside their house. And so the goal is really to identify what are some of the objectives for the family and how can they each support each other. So the family's worried about this young girl that's going to attempt suicide, so we had to have an active conversation about, so when you isolate, how can you share this with your family so that they're not going to respond in their past traumatic triggers? And then they negotiated it. They negotiated what she needed in order to be able to have that time by herself, but that she could hear what their concerns were, and then they were able to negotiate back. That becomes the important piece in the goal of involving the families, because without it, they continue to go into their old behaviors. I'm going to wrap up with the next couple of slides. I know it's looks like it's 11:52, so I'll make sure that I'm going to end us on time. And so how is this a systemic issue? I've given you the case examples kind of throughout there. And so recognizing those relational patterns. The interaction between family members is so overwhelmingly powerful that the subtleties, if they're not involved in it, can get lost. And I will give you one more example as we kind of look at, so what do we need to do in regards to promoting recovery for families, is a young couple whose the husband was in substance use treatment. And he was trying to identify and attend meetings and go to his sponsor. And what the wife had said was, I don't understand, if he's been here for that many days, why would he go to somebody else instead of me when he's having a hard day? Now, had that couple not been in treatment together, what would have happened is he would have tried to call a sponsor every time he was having an urge, which would have been appropriate and what would have been recommended by his treatment team. But she would have felt left out because in the past when he was actively using, she was taking care of him. She was the one that he went to when he was upset. She was the one trying to convince him not to use. When he did end up using, she was the one that took care of him and made sure that he was okay. So when all of a sudden he starts to get emotionally vulnerable and he goes to somebody outside of his marriage, she's going to see that as a threat, not as a personal threat, but she's not going to know what her role is. And they're likely going to fight, which was what was already occurring. And so having them together where you could say, how else can you guys connect? Because what he's doing, and he could explain why he went to a sponsor rather than her, because when he said, if I told you, you would be upset, and that she could, because we created safety for her, say, you're right. If you told me you were going to use, I'd get really upset. And so then we were able to negotiate, how do you guys still stay connected? Because what you were connecting with is the disease. What you knew how to stay connected to each other was when this disease was present. And now what we're saying is not only are we trying to get the disease not to be present, but when he's starting to find his recovery, he's going elsewhere. He's going to outside meetings and he's talking to other people. So that vulnerability that she would feel, how do you still stay connected? And that they problem solve. That's that importance of making sure that you pull them in. And so promoting the recovery for the families, again, helping them to be part of the recovery and not the addiction. That you can't save them from themselves, but you can love them and set up the boundaries and highlight those discrepancies. There we go. Sorry. And that the support. So when we start to look at how do we want to help families to be present in the moment, that idea that it's okay to be happy today, that you can still laugh with your loved one and not know the answers to the predictability of the chronic illness that they're feeling and struggling with, and that it's okay to be afraid of the old behaviors, but recognize that when you start to become afraid of it and you get stuck in it, the limbic system is going to take over and you are going to start engaging in behaviors that are more reactive and impulsive. That if you are wanting to be problem solving, if you're wanting to be able to figure out how to think through everything, that you need to be aware that you've got to calm that limbic system first to be able to utilize that cortex, and that that's helping to support the family to understand those things. And then on that, to helping the families to be consistent, I always say to helping them, right, you're both on a boat and theirs has got holes in the bottom of it, and you are so desperately trying to lean over your boat to pull them into yours. But because of that trajectory of you leaning so far over to pull them into yours, you are more likely to fall into their boat. And so in order for you to be able to build the foundation of recovery is that make sure your boat is sturdy and make sure that you have done what you need to do for yourself. Make sure you have taken classes and gotten the education and the support that you need. Because when your loved one is ready and able to have the sustained recovery, they will lean up to you for you to pull them into their boat. But if you are leaning over your boat into theirs, you are more likely to fall into theirs that is full of holes. And so helping them to be consistent, that emotion regulation is a key piece, particularly when we're talking about trauma. And that's the mindfulness, that's detaching from the crisis, that's living in the moment, and then providing the hope for the families. New science shows that kindness and positive reinforcement are some of the best ways to succeed in motivating change. So that is it. If there are any questions, I know we have a couple minutes, so I want to make sure that I'm leaving a couple minutes in the event that there's any questions. I did see somebody asking if there was a handout in Spanish. I do not have this interpreted in Spanish, but I certainly can share the handout. I don't know if somebody is able to interpret those for me, but I can certainly share the handouts for the PowerPoint. Well, if there are no other questions, then I will kind of just end in this, how to help the natural support to empower their loved one, that education, so providing them the education, an understanding of what is going on with somebody, to teach them the skills to improve the relationships that they have, to bring the family in. The sooner that you bring and contact a family, the stronger that partnership is going to be in setting up communication and appropriate boundaries, and then to offer advice in relationships to allow for them to start to be the director of how to problem solve while you're co-facilitating, looking at how to do that. So I appreciate everybody's time. I hope this was helpful. for those of you that were able to participate, and I'm certainly happy to share it. I'm not sure how, I guess it'll be on the website.
Yes, Trish, and we just wanted to thank you for, you know, just troopering through this, because I know it was difficult for you, but it was a very interesting topic, and I think you touched a lot of questions that people had.
Wonderful.
So,
Wonderful.
With that being said, I'm going to go over some housekeeping slides with the group that's interested in the CEUs. When I conclude today's webinar, your browser is going to take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You'll be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile on FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. The evaluation will close at midnight on Friday, February 21st. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. We just want to thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.